Hi, everybody. I'm going to get started shortly. So throughout this presentation, I'm going to be using Poll Everywhere. So that's the link if you want to pull it up on your phones or computers, and then you could also text and participate that way as well. Okay, so I think I'm going to get started. So hello, everybody. Thank you so much for joining my CE today. It's titled, "Oh Baby, Medication Safety and Potentially Inappropriate Drugs in Pediatrics." So as for disclosures, I don't have any disclosures. And for our objectives for our pharmacists, we're going to be talking about important components of the CDC's PROTECT initiative. We're going to discuss pharmacokinetic principles and how they differ from children and adults, and pediatric dosing and drug references. We're going to talk about some of those, as well as the kids list, which is key potentially inappropriate drugs in the pediatric population, and talk about some drugs that are on this list. And for my technicians, we're going to go over the different age categories for pediatric patients. We're going to define what an adverse reaction is and learn the impact of them on the healthcare system, and talk about the PROTECT initiative as well, and the kids list too. So before we start, I do want to go over the pediatric age classification. So this chart has all of the different terminology here for you. So a neonate is from birth through 28 days of life. Infants are from 29 days through under 2 years old. Children are 2 years through under 12 years, and adolescents are from 12 years through 21 years. So what is an adverse drug event? So the CDC defines it as harms resulting from the use of medication, and they include allergic reactions, side effects, over-medication, and medication errors. So an adverse drug event is really an umbrella term that encompasses all of these different things that can occur. So it's simply put, it's someone is harmed from taking a medication. Now, these adverse drug events, like I said, it's an umbrella term that encompasses everything shown here on the slide. So there's various different types of these adverse drug events. So for example, a drug allergy, commonly patients have penicillin allergies, subtherapeutic and supratherapeutic dosing. A good example of that is vancomycin. We always target our trough and our AUCs, and by under or overdosing, that is an adverse drug event. Also withdrawal, drug withdrawal. So for our patients who are on opiates long-term for chronic pain, if they go without a medication, without a dose of their medication, they can experience withdrawal from that medication. Also treatment failure. So an example of that would be a patient who develops a clot and they're taking warfarin or Eliquis. And so adverse drug reactions are a specific type of adverse drug events, which we are going to talk about next. So now, what is an adverse drug reaction? So it's defined by the World Health Organization as any noxious and unintended response to a drug that occurs in man at doses normally used for prophylaxis, treatment of diagnosis of disease, or for the modification of physiological function. So the biggest key with this is the word unintended. So this isn't something that we are really intending to occur. So the drug is given at the correct dose, so we're not supra or subtherapeutic dosing with this. And then adverse drug reactions can also be benign or harmful. They could be iatrogenic and unpredictable, or unintended and expected. So an example of one that would be expected is a patient who started on steroids. They may experience a lot of insomnia and increased hunger. Now, we're going to talk about adverse drug reactions in pediatrics and their healthcare impact. So the incidence of adverse drug reactions that leads to hospital admission in pediatric patients ranges from 0.4 to 10.3%. So this data comes from different studies. It really depends on the study that you're looking at, and it is a pretty big range, but 10.3% is a pretty high percentage. Now, the incidence of adverse drug reactions in hospitalized pediatric patients is even higher at 16.8%. And then there was actually a study in a large British children's hospital. It showed that adverse drug reactions were responsible for 4% of admissions. So that's really an incidence of 4 adverse drug reactions per 100 admissions. So this study included admissions over a 2-week period. So they saw that in 71% of cases, the adverse drug reaction directly led to their admission. And then they concluded that 33% of these reactions were actually possibly avoidable. So these were things that we could have prevented in the community that prevented them from even coming to the hospital in the first place. And so here's my first poll for everybody. You can respond on your phone or via text. So in children under 5 years old in the United States, about how many ED visits per year are due to unintentional medication overdoses? If you're unable to pull up the Poll Everywhere website, you could also feel free to respond in the chat or unmute yourselves as well. So I see a lot of you are saying 15,000. So let's find out. So actually, each year in the United States, about 50,000 ED visits are due to unintentional medication overdoses among children under the age of 5, which is a very high amount of patients. And actually, each year, 1 in 150 2-year-olds are in the ED for a medication overdose. And now that's just 2-year-olds alone. That's not including any other age. That's just 2-year-olds. And most visits, more than 90%, are due to kids getting into their medication on their own without any caregiver oversight. And about 5% of ED visits are due to unintentional medication overdoses due to medication errors. So the most common error is when a caregiver may accidentally measure and give too much medication to their child. So those statistics were pretty alarming. So now introducing the PROTECT initiative. So the PROTECT initiative really is looking at preventing kids from coming into the ED in the first place. So this is an outpatient initiative. We're really stopping the problem at the source. So we're looking at how we can promote medication safety in these pediatric populations. So it was a CDC-led public-private partnership, and it was a collaborative data-driven approach. So it wasn't just the CDC that led this. It was the CDC with other government agencies, pharmaceutical manufacturers, packaging companies, which play a large role here, as well as professional organizations and nonprofits and many more. So initially it was focused on just looking at over-the-counter medications, overdoses, but then they recently expanded it to focus on unintentional overdoses of prescription medications by children as well. So it's a 3-step approach. So it's safer packaging, safer use, and safer storage are the 3 components of the PROTECT initiative. So first, we're going to talk about safer packaging. So safer packaging really can prevent unsupervised medication ingestion and help to limit how much medication that children can access on their own. So these PROTECT participants, like I mentioned before, they developed and refined the concepts of the pediatric exposure limiting packaging. They then went ahead and assessed its efficacy and then encouraged implementation of this packaging. So one thing they did, like I said, they implemented the innovative safety packaging. So in 2011, manufacturers of OTC medications committed to incorporating new product enhancements for infants' liquid acetaminophen products, which included adding flow restrictors. So that's shown in the picture on the right. So flow restrictors are really adapters that are added to the necks of the bottles that limit the amount of liquid that can come out of the bottle. So even if you're turning the bottle upside down, you're shaking it, you're squeezing it, it's still serving as an extra barrier to prevent medication from just freely flowing out of the bottle. And so what they did with this was they demonstrated the efficacy of this enhanced packaging. So that was through this trial. It's called the Efficacy of Flow Restrictors in Limiting Access of Liquid Medications by Young Children. So their objectives, it was to assess whether adding flow restrictors to liquid medicine bottles can provide additional protection against unsupervised medication ingestions by young children, even if the child-resistant closure isn't fully secured. So they assessed the amount of liquid that was accessed and the time to empty the medicine bottles. So the study design, It was a multi-site randomized trial that took place between April to May of 2012, and it included 110 children aged 3 and 4 years old from 5 preschools in the Atlanta metropolitan area. So the methods of this trial, there were 2 consecutive trials. So the children were asked to get everything out of a bottle that was filled with a test liquid in these trials. So the one trial, they had an uncapped bottle. It had a flow restrictor, and at the time there were 3 different types of flow restrictors in production, so they tested each of those. And then the other trial, they had the control bottle without a flow restrictor, so it either didn't have a cap on it or the cap was incompletely closed, and the caps were those child resistant caps that we're used to, the push down and turn ones. So they gave them 5 minutes initially they told them get all the medication out of the bottle. And if they didn't empty the bottle after 5 minutes, the tester demonstrated how you would take the liquid out at home to simulate what they might see. So then they could kind of go and replicate it. So they also were given the same dosing syringes and dosing cups like you would have in a household. So they also reminded the children that they could use their teeth even to get the medication out. And then they gave them an additional 5 minutes. So the results of this trial were actually very promising. So for the open control bottle, that's the bottle that didn't have a flow restrictor and didn't have the child resistant cap. So all but one of the bottles were emptied within just 2 minutes, and all of the children removed more than 25 mL of liquid from the bottle. In the incompletely closed control bottle, that was the one without a flow restrictor as well, but the cap wasn't fully closed. 82% of the bottles were emptied in 2 minutes, and then 90% of children removed more than 25 mLs. Now, comparing that to the flow restrictor bottle, only 6% of those bottles were emptied during the total 10-minute test period, and none of the bottles were open in under 6 minutes. So even 11% of children were able to remove more than 25 mLs of liquid. So those children that removed more than 25 mLs of liquid from the flow restrictor bottle, those children were mainly older children. So there were 12 children that did that, and 10 of them were from the oldest age group, which is 54 to 59 months. And none of the youngest children in the group of 36 to 41 months removed even 5 mLs of liquid from the flow restrictor bottle. So some of the strategies that the children tried to remove liquid from the bottle were really interesting. They tried the dosing syringe, and all the children that removed more than 25 mLs did use the syringe. They tried pouring, shaking, squeezing the bottle. They even tried using their teeth or attempting to manually remove the flow restrictor. One child actually used their teeth to get it out and then actually was able to empty the bottle, but that was only 1 out of the total 110 children. And it also even tried drinking from the bottle as well. So what did this study really conclude? It's that child-resistant caps are only efficacious when completely resecured. Not only did flow restrictors decrease access, but it also decreased the amount of access because they were able to get less medication out. So it really shows that combining these child-resistant caps with the flow restrictor did lead to enhanced safety. And because, like I had said, none of the children were able to get medication out in under 6 minutes, that's honestly better because the more time it takes, if the parent's not watching them, say they're doing the dishes and the kid's getting into medicine, kind of in a way buys them more time. So that way it's not like the medication's coming out right away. Now we're going to discuss safer use. So the goal with safer use is really to be clear and consistent with volumetric measurements on liquid packaging to help limit these dosing errors. So the dosing devices listed here include oral syringes and dosing cups. And the Protect partners actually initiated and led activities to improve this as well. So the first safety improvement was created a guideline for standardizing the measures on OTC liquid medications. So this is the CHPA guidelines. They actually updated it in 2014 to reflect growing support for a single volumetric unit, which is mLs, when dosing liquid medication. And then they evaluated how well they adhered to these guidelines, as well as the FDA guidance for OTC medications. So then they found the results that they found, they shared that with manufacturers, so that way they can address any areas that needed improvement. And this was on OTC medications. And then they created a standard for safe use, which is the NCPDP recommendations. This is on prescription medications. So what their recommendations were was that always have milliliters as the standard measure, to always use leading zeros and not use any trailing zeros. And then dosing device units have to match what's on the container label, as well as being easily available in a syringe or a dosing cup when dispensing this medication. So the big thing with why they chose milliliters versus teaspoons, well, first, milliliters and teaspoons are very different measures. If you by chance read one and you think teaspoon, like 1 teaspoon was a common measurement, 1 ml versus 1 teaspoon is a very big difference. Also, the issue with teaspoon is that parents were using actual teaspoons found in their kitchen to measure the medicine, not an actual teaspoon measurement. So it's very easy for them to not have like the dosing cup or the syringe at home and just grab a teaspoon and think they can use that. But those aren't standardized units on that. It's just called a teaspoon. So this really helps to promote medication safety and preventing any overdoses in children. So the last part is the PROTECT initiative, safer storage. So really it focused on education on safe storage to complement the safer packaging that they implemented. And they also wanted to make sure that people were aware in case of an emergency where a child did ingest medication. So these safety improvements for safer storage included developing an educational campaign, which is the up and away and out of sight campaign. So the different parts of this campaign include out of reach, which is picking a place to store your medication where children can't reach it. And then putting your medications away, so not leaving loose pills or liquid medications on any counters, tables, or on your nightstand where children can easily access it. Here, the click is suggesting that people keep medications in the original child-resistant containers, which makes a lot of sense. I know a lot of people use pill boxes and non-safety caps, or even store their medications in like Ziploc bags, where it's so easy access for them. But in a household with young children, that's not a good idea because they easily can get into it the way you can easily get into it. Also, teaching your child about medication safety. So it's really important to educate children from a young age once they're able to understand what medication is, just educating them as well. And telling your guests. So discuss keeping medication in a safe place. So say you have a young child at home, if you have like, say your parents are coming to visit, say one of them may take any medication really, but say they take like warfarin, making sure that when they come and if they're staying for an extended period of time, making sure you're putting their medication away and not just leaving it out for them. And the last part is really just continuing the dissemination of these safe storage messages. So they had a lot of activities that I participated in and different media outlets that they were able to provide this information, such as social media, radio, video, all over, just to really spread the word. So this poster is actually from the Up and Away campaign website, and I really like it. At the top, it shows gummy bear or multivitamin, and you can see how they look really similar. So I know, especially in recent times, there's been a lot of stories on the news about children getting into their parents' THC gummies, which is really unsafe and can really cause a lot of harm to children. So that's something that really you want to make sure that you're storing something like that far away from kids. Even melatonin, like I take the melatonin gummies myself and they taste delicious, but I'm an adult and I know the difference between medication and candy versus younger children. They might see like a multivitamin thinking that it's a gummy bear and be inclined to eat it. And also something I really like about this poster is to never refer to medicine as candy when you give it to your child. So as appealing as it may seem to tell children it's candy to make them want to take it, they can actually misinterpret that and interpret what you're saying very literally and think it actually is candy and then want more or try to get more out of a bottle to have more of it. So it's really important that in any circumstance, don't tell your children that medication is candy. So this slide is just a summary of everything I talked about with the PROTECT initiative. Really, just I want to emphasize that this is an outpatient initiative to prevent children from coming into the ED for an accidental medication overdose. So really stopping it at the source of the problem. So now we're going to be switching gears and talking about pharmacokinetics in pediatrics. So some overall principles is that a child is not a small adult. I know a lot of people say pediatrics is like treating small adults. It's really not, because children do have variations in dose response, pharmacokinetics, pharmacodynamics, and their age is actually correlated with the different pharmacokinetics because they have changes in absorption, distribution, metabolism, and excretion. So growth and development from birth to adolescence really is a dynamic process. And because of this, they're actually at a higher risk for adverse drug reactions because of these maturational changes in their body composition and organ function. So as for absorption, for the GI tract, children do have increased gastric pH and a slower gastric emptying time and motility. Intramuscular, they have decreased muscle mass, and it's really difficult to predict absorption. So we try to stay away from intramuscular route of administration, unless if there's an emergency or they can't get IV access. And for skin, neonates actually have a thinner skin, so they have increased cutaneous absorption of drugs. So for example, if you have a child with, say, a diaper rash, you wouldn't want to give them a topical steroid because they'll absorb more of that steroid than someone like us as adults would. In terms of distribution, body composition changes over the first 10 years of life. So I want you to think of infants as little sacks of water. They have less adipose tissue and more total body water. So because of that, they have a lower volume of distribution for drugs that are lipid soluble and a higher volume of distribution for drugs that are water soluble. They also have decreased plasma protein binding because they have decreased albumin. For metabolism, premature and full-term neonates actually have underdeveloped enzyme systems, and they mature over time. So in infants, metabolism is much slower than in older children and adults. So the CYP450 enzyme system, that's one of the enzymes that metabolizes a lot of our drugs. It's actually lower than adults at birth and higher than adults at 6 to 12 months. So when you're verifying orders for any of these patients, it's important to keep that in mind as well. Now for excretion, as we know, kidneys are what clear a lot of drugs from our body. So renal function is not fully developed until a few weeks to 1 year after birth. So infants do require a lower total daily dose of drugs that are eliminated by the kidney, especially during the first week of life. So as they get older, these dosage requirements will increase with age. Now for our pediatric dosing principles, it's really important to remember medication doses are often based on their body weight. So you do want to make sure that when you're verifying an order, you're using an accurate and up-to-date weight, and it's in kilograms. I know here our weight is always written in kilograms. I did have a scenario, not on my pediatrics rotation, but where I did have a weight for a patient entered as 200 kilograms, but they were really 200 pounds. So always being cautious if you're seeing an order and their weight looks like way heavier than what they should be. It's never a bad idea to question that before verifying an order. Also, certain drugs such as chemotherapeutic agents may be dosed based on body surface area. And generally, the doses that are calculated for pediatrics shouldn't exceed a typical adult dosage unless if there's any literature or guidelines that support this higher dosage. So where do we find this dosing? It's found in these references: the Harriet Lane Handbook, Pediatric and Neonatal Lexi Drugs, and Micromedics Neofax in Pediatrics. So the Harriet Lane Handbook is updated by residents and faculty at Johns Hopkins every 3 years. And it's fast information for pediatric diagnosis and treatment. So I like to think of it as like up to date for pediatrics because it does have so much diagnostic information. It's available in print and digitally. Digitally, we do have access. This is a screenshot that I took from our webpage, is what it looks like when we go into the Harriet Lane Handbook. So it groups it by system as well. So as you can see, there's cardiology, dermatology, and different ways to find the information in a clear and concise way. So for pediatric and neonatal Lexi drugs, that's available through LexiComp. So whenever you search for a drug in LexiComp, this is what you see. So you'd always want to make sure you're picking the pediatric and neonatal Lexi drugs when you're looking up doses for a pediatric patient. As we know, it has updated dosing, administration, storage, adverse reactions, and pharmacokinetic information as well. what I found really interesting is that certain drugs actually do have specific pediatric pharmacokinetic information of those drugs. So there's some drugs that you could actually find that information for, and it'll say like adult dosing unless otherwise noted. So you have a lot of information available to you. Now, micromedics, they have neofax in pediatrics. This is very similar to LexiComp. It includes drug monographs and dosing calculators. So you could put in on the right, that screenshot is actually of one of the dosing calculators. So you would put in their age, their weight, and then you would from there proceed to like pick a drug, and it would provide you with a weight-based dose, which is very neat. It also has enteral formula information. So if you ever had any questions pertaining to that, you could find that information there as well. And so it's very similar to LexiComp. So the neofax and pediatrics really does have all the dosing, administration. They have some solution compatibility as well as injection site compatibility. And this is also available via internet and a mobile application. Now, so for the pharmacist point of view, I have a question. You're the pharmacist to order entry. You see an order come in for 6+1 for a 2-month-old who's 5 kilos. It's for IV ceftriaxone 2 grams, Q24 for UTI. Would you verify this order? Yes or no? Feel free to respond in the chat or unmute yourselves. Anybody? No. Good. Okay. So no. So here's a screenshot I took from LexiComp. Tells you the dosing. So it's 50 milligrams per kilogram per dose every 24 hours. So the correct dose for this patient would really be 250 milligrams per day, which is way off. And I know this is a very exaggerated example, but it really serves a true point at order entry, always making sure you're checking your doses when verifying medications for peds. And then even at IV bench, or if you're at oral syringes or in the main, whenever you see a label that has their age and their dose on it, you want to think about it logically. Like if you're drawing up a syringe of 40 mLs of something for a pediatric patient, you probably should know that that's not always, most likely not going to be correct. And for my pharmacy technicians, you're the technician at VC3 and you see a label print for Brio Ellipta inhaler for the NICU for a baby born today. Would you grab this and scan it and fill it, or why or why not? Anybody? Good, yeah. So this is leading into a teaching point I would like to share with you. So there's other types of inhalers. There's dry powder inhalers versus metered dose inhalers. So dry powder inhalers, the medicine's released into the airways when you take a deep, fast breath in. So it would require a quick, forceful inhalation, and you can't use a spacer or any holding chambers with the dry powder inhaler. So an example of one is Brio Ellipta. And then metered dose inhalers, those are different. They're pressurized inhalers and they release the medication into a fine spray to inhale. Those you can use with a spacer to allow for ease of use. And an example of that is an albuterol metered dose inhaler. So this is what they look like. So the dry powder inhalers, you can see there's the mouthpiece. You need to be able to put your lips around the mouthpiece and be able to fully take that big breath in to get the medication into your lungs. A baby that was born today most likely cannot do that. And then versus the metered dose inhaler, that can attach to a spacer, which kind of has that holding chamber in the middle. So even though you press the button and the medication's released into there, as you inhale, it'll come into your lungs. And now not every situation is as clear as this, but if you see anything that looks questionable, it's always a good idea to ask and make sure. So even though you're not the one putting through the orders, you could still play a role in medication safety, especially those in the vulnerable pediatric population. Now moving on to our last section is the kids list. So it stands for Key Potentially Inappropriate Drugs in Pediatrics. It was created by the Pediatric Pharmacy Association in 2020. And it talks about drugs that should be avoided or used with caution in all or a subset of the pediatric population because they pose an unnecessarily high risk for children and a safer alternative is available. So it contains 67 drugs and drug classes with 10 excipients. The most common groups include drugs that are anti-infectives, antipsychotics, dopamine antagonists, and GI agents. And most of these drugs are available in multiple dosage forms, including oral, parenteral, and external routes. Now I have my next question. Can anybody think of any medications that are inappropriate in pediatrics? Feel free to type anything. Doxycycline. Lamotrigine. I saw that in the chat. Ceftriaxone. Good. So there's a bunch of others, but good. You guys have the right idea. Aspirin. Good. All right. Oops. So which of the following antibiotics are on the kids list? There's two that are the correct answers. Ceftriaxone. It's one of them. C, chloramphenicol. Yep, those are actually the two correct answers. Good job. So ceftriaxone is known to cause kernicterus. So during pregnancy, the mother's liver removes bilirubin for the baby. But once the baby's born, they have to remove that bilirubin themselves. And some babies, the liver isn't fully developed enough to efficiently get rid of bilirubin. So most newborns actually appear jaundiced because of this bilirubin buildup in their blood. So bilirubin is made by your body when you break down red blood cells, and it's actually found in your bile, and it helps you digest food. Jaundice is really that yellowing of skin in the eyes that you do see in a lot of newborns. So kind of tying this back into our PK that I was talking about earlier. So ceftriaxone is highly bound to our plasma proteins, and it can actually displace bilirubin from those sites and make that jaundice worse, causing kernicterus. So you have this buildup of that bilirubin. And then kernicterus is kind of the end result of this long-standing jaundice. It's actually characterized as brain damage that can result from high levels of bilirubin, and it can cause also vision problems, hearing loss, and intellectual disabilities long-term as well. So in the package insert, there is a contraindication for ceftriaxone in neonates and preterm neonates that are hyperbilirubinemic, which is high bilirubin, as well as neonates that require or are expected to require treatment with calcium-containing IV solutions, because the calcium in ceftriaxone can actually bind and then precipitate in the lungs and kidneys. So the kids list recommendation is caution in neonates. So caution kind of meaning a soft stop, except in those situations at the top that then where it's actually contraindicated. So if you ever get an order for it, it's something to approach with a lot of caution. And so next is chloramphenicol and gray baby syndrome. Chloramphenicol is not really a medication we see very often, but in the pediatric population, it can be used for meningitis or a severe infection. For adults, it's actually indicated for the plague, Yersinia plague, which hopefully we won't see ever again. But it isn't a medication that is still on the market. It also is a really good example about what I said earlier about pharmacokinetics. So gray baby syndrome, it looks like abdominal distension, hemodynamic collapse, and gray skin discoloration. So you have the neonates that are unable to synthesize and recycle the enzyme that you need to metabolize chloramphenicol. And then tying into excretion as well, the kidneys aren't able to excrete the chloramphenicol and its metabolites. So it just kind of builds up in the blood. And then it can also lead to displacing bilirubin and kernicterus as well. So their recommendation is to avoid in neonates unless they use serum concentration monitoring. So avoid is more of a hard stop. So you wouldn't want to give this medication unless if you actually monitor their serum concentration of it. So I have another question. Which of the following medications are on the kids list? There's 2 of these as well. C, B, and C. Correct. Good job, guys. Those are the 2 medications from here. So codeine first, codeine can cause respiratory depression. So codeine is actually a prodrug. So that means that when you take codeine, it's not actually active. It needs to be converted by CYP2D6, which is just an enzyme in our liver that converts it to morphine, which is the active form. Now, there's different types of like some people metabolize codeine or CYP2D6 faster than others. So those are your ultra rapid metabolizers. So they're metabolizing that codeine faster than normal. So they have more morphine in the body too quickly. So that's why codeine is actually contraindicated in all children under 12 years old. And then in children under 18 years old after tonsillectomy or adenoidectomy. So you want to make sure that you also avoid it in children 12 to 18 with other risk factors that may increase their sensitivity to the respiratory depression effects. So those risk factors are really any conditions associated with hypoventilation. So being post-op, such as after a tonsillectomy, having obstructive sleep apnea, being obese, severe pulmonary disease, or other medications that also cause respiratory depression. So the kids list recommends avoid in children unless pharmacogenomic testing is utilized. So the avoid is more of a hard stop. So unless if you get this testing that proves that they're not a ultra rapid metabolizer, you definitely do not want to use it. So I know earlier I broke down all of the different age groups of pediatrics, but I do want to specify on the kids list, they do classify children as anyone under the age of 18. So this makes a lot of sense and it correlates to the contraindication. So under 18 years of age. So next, I want to talk about propofol and propofol-related infusion syndrome. So that's defined as an acute refractory bradycardia leading to asystole in the presence of more than one of the following, or one or more of the following. So acute refractory bradycardia, that's really just a slow heart rate that's not responsive to any treatment. And then asystole is a medical term we use basically for flatlining. And so in the presence of one or more of the following, so metabolic acidosis, rhabdomyolysis, which is the sore muscles that is a common side effect of our statins, hyperlipidemia, and an enlarged or fatty liver. So it's really a rare syndrome, but it does have a super high mortality rate when it does occur. So the proposed mechanism, the mechanism isn't known, but we think it's due to mitochondrial defects, which then inhibit the transportation of the fatty acids into the cell and interfering with phosphorylation, causing the arrhythmia and the metabolic consequences. So essentially, it's really an imbalance between having a high energy demand and being unable to utilize it, which can then cause that cardiac and peripheral muscle necrosis. So propofol-related infusion syndrome does occur at a higher rate in children than adults because higher rate doses of propofol are needed, especially in status epilepticus, which is a type of seizures. So the higher doses are often required just to control seizures for an extended period. So that's doses that we see of more than 4 or more milligrams per kilogram per hour for 48 hours or longer. It also too, with procedural sedation, the dosing is lower and it's for less time because it's only during the procedure. So that's why it's even more harmful in this scenario. So some risk factors of developing propofol-related infusion syndrome, the dose and duration, like I had just mentioned, that dose, as you can see, lines up with the higher doses that are commonly required. Young age and critical illness. So they recommend avoiding doses more than 4 mg per kg per hour for more than 48 hours. So if you ever see a dose like that, the avoid is more of a hard stop. And so children, again, is defined as under 18 years old. So true or false, it is best to give children aspirin for fevers and bismuth subsalicylate, which is Pepto-Bismol, for upset stomach. Correct. It is false. So these are salicylates, and those can cause Reye's syndrome. So Reye's syndrome is an acute non-inflammatory encephalopathy associated with fatty liver degeneration, and it's usually preceded by a viral illness. So encephalopathy is really just brain damage. And the mechanism is thought to be due to having mitochondrial injury that's actually intensified during the viral illness, which then causes the ammonia to build up in the body. So you have your liver that's unable to function as well because of the viral illness. So with the ammonia building up, that could cause the encephalopathy. As we know in like cirrhosis patients, like adults, commonly hepatic encephalopathy is something that we see. So their presentation, they present with severe protracted vomiting, encephalopathy that may progress to coma or death. So their recommendation is to use caution in children with either suspicion of viral illness, known viral illness, or who are recovering from viral illness. And these include influenza and varicella, which is the chicken pox. So this incorporates all children under 18 years old again, because the kids list, they define children as under 18 years of age. And so my last one, I think I may have forgotten to clear the answers from this. But so which medication is on the kids list? It's lamotrigine. So lamotrigine can cause skin rashes. So that's due to a hypersensitivity reaction to the drug, which is basically your immune system overreacting to a compound that's present in it. So it can vary in intensity. It can be from a transient mild rash to full-blown Stevens-Johnson syndrome, which is a rare but very serious disorder that starts out looking like the flu, and then it progresses to having a really painful rash that spreads throughout the body and causes blistering. So children in general are more predisposed to skin rashes than adults are. So one of the predisposing factors to developing these skin rashes is a rapid dose escalation and using high initial doses. So it's not a complete contraindication to using lamotrigine in children, but you do want to make sure that you use caution, and using a slow titration is required. So you really want to adhere to the recommended initial dose, the titration schedules, and then adjusting to reduce the risk. So you can actually find this titration schedule depending on what type of seizures you're treating on drug references like LexiComp and Micromedics, Neofax, and Pediatrics as well. So for children, again, is defined as under 18 years of age. And so in conclusion, adverse drug reactions have a large impact on the healthcare system. The Protect Initiative approach focuses on 3 pillars: safer packaging, safer use, and safer storage. Pharmacokinetics differ in the pediatric population from adults. In pediatrics, medications are mostly dosed based on their weight. There's multiple pediatric drug references that are available to pharmacists, and the kids list is a useful tool that establishes drugs to avoid and use caution with in the pediatric population. So thank you all for your attention and for joining today. Does anybody have any questions? So if nobody has any questions, thank you all so much for joining me today. I hope you learned something. I'll be sending out emails shortly with all of the questions for so that way you could get your credit, and I will provide you all with the codes. Thank you guys for coming.